Skeletal dysplasia is a complex disease, and their treatment requires several disciplines and strategies. The neurosurgical approaches to patients with these conditions are similar. The three conditions, hypochondroplasia, achondroplasia, and thanatophoric dysplasia, are clinically related dysplasias caused by the gain-of-function mutations on the fibroblast growth factor receptor 3 gene. As evident in this slide, the prevalence does vary according to the specific diagnosis. Chondroplasia has the mildest phenotype, followed by achondroplasia, and followed by the more severe form of the thanatophoric dysplasia. These diseases can vary in their severity within and between families, and frequently lack some of the neurological complications that is associated with the different types of skeletal dysplasias. The common features are short stature, macrocephaly, joint laxity, genu varum, hypotonia, lumbar lordosis, and a small as stated earlier, these three conditions manifest themselves from minor to mild symptoms or clinical features to the more severe forms of clinical features. Your hypochondroplasia, children typically may have normal faces, may develop osteoarthritis as adults, and can present with acanthosis nigrans. In achondroplasia, one is likely to see the mid-face protrusion as well as the thoracolumbar kyphosis, which is much less common in your hypochondroplasias. In the more severe or more clinically evident form of the thanatophoric dysplasia, you can see the clover leaf skull deformity, a large anterior fontanelle, the classic facial features of the flat face, frontal bossing, and mid-face retrotrusion, and ocular proptosis. They typically have a small bell-shaped thorax, however, relatively normal trunk, and there will be evidence of redundant skin folds. As expected, one can also find the classic radiological features in this condition, and it really depends upon the phenotype as to the severity of the radiographic findings. These may include long bone shortening, short and broad femoral necks, a narrow lumbar interpeduncle distance, short lumbar pedicles, the short and square-shaped ilia, a horizontal acetabulum, and prominent muscle insertion on the long bones. More common in your achondroplasia or your thanatophoric dysplasia with the proximal femoral radiolucencies and this narrowed sacroiliac notch. The others can be a narrow foramen, circummalar compression, decreased vertebral body disc height, as well as increased nuchal translucency and well-ossified skull. And surgical complications include in hypochondroplasia are the seizures with temporal lobe epilepsy, intellectual disability, and learning disabilities, all evident. Whereas in the achondroplasia, some of the neurosurgical complications include hydrocephalus, the cervical medullary compression or stenosis, and spinal stenosis both in the cervical and the thoracolumbar region. And occasionally one can see subdural hematomas given the treatment of hydrocephalus. And in the more severe form, the thanatophoric dysplasia, one sees similar findings as the achondroplasia and hypochondroplasia, but one can also see the cortical polymicrogyri and the pyramidal tract hypoplasia, the megaloencephaly, as well as possible encephalocele.